Thank you, Mahesh, for that wonderful introduction. And thank you, Dr. Tony Fernandez Hospital, Dr. Sheena, Dr. Mini, and Dr. Freddy for this kind invitation. It's really an honor and a privilege to be here and to meet all the SN alumni here. Although it makes me feel very old when Mahesh introduces like that, but nonetheless. Okay, so it's so far it has been a really wonderful meeting and a lot of insights from all the talks. So I am going to talk to you about navigating challenging landscape of PDR surgery. So I was given the brief that this audience is a mix of anterior segment surgeon, posterior segment surgeons, and also non-ophthalmologists. So the talk I have tried to make it cater to all the types of audience. So but there might be some repetition, and so bear with me. So we know that pathophysiology of diabetic retinopathy, that there are changes which occur in the microvascular, the capillaries of the retina, which lead to microvascular leakage and microvascular occlusion, and that leads to these changes of diabetic retinopathy, where you see blood vessel leakage, hemorrhages, hard exudates, and ultimately formation of new vessels, that is the new vessels at the disc, which is called as NVD, and new vessels elsewhere, which is called as NVE. And as you know, the diabetic retinopathy relentlessly progresses from mild to moderate to severe and to proliferative diabetic retinopathy. And if left untreated, it can lead to a lot of complications in proliferative diabetic retinopathy, leading to sight-threatening problems such as vitreous hemorrhage or tractional retinal detachment. So how to navigate these challenges? So if you ask any postgraduate student, what are the indications of vitrectomy in diabetic retinopathy, pat will come the answer that it is a non-resolving vitreous hemorrhage is the indication, and tractional retinal detachment is another indication. But is it as simple as that? So it's not. There are a lot of nuances to this. And that is because of the diverse manifestation of diabetic retinopathy. All this discussion that we have been doing is because the diabetic retinopathy presents with so many varied manifestations and so many features that each patient gives a new challenge to us. And despite having so many years of experience, you still you will find patients who are challenging to even the experienced person also. So there are several patient-specific factors which play a role in this decision making, and that is the duration of diabetes, how good has been the metabolic control overall, what was the baseline retinopathy status and what is the status now, what is the other eye status, what are the other underlying systemic conditions, etc. So when you are treating a patient, you have to take into account all these conditions and then come to some plan which will be beneficial for the patient. So this talk is going to be more of a patient-centered and case-based discussion rather than a theoretical discussion. So this is case number 1, and if you look at this case, you have this is a fibrovascular polyp here extending from the disc, and this is the rest of the retina. You can see some small polyp here, small polyp here. So if you look at this, you might probably think that, okay, this is probably a operation case and let us do some vitrectomy. And this is the OCT. OCT is showing you there is some traction here. The fovea is attached. So this is a 55-year-old man. The right eye is already has lost due to, it has had an unfavorable outcome for vitrectomy and silicone oil surgery done elsewhere. And now this is the only eye the patient has. Vision is 6/24. Now you will feel that, okay, let us help this patient. Maybe we will do the surgery in this eye and help the patient. But wait, look at the patient again. See this. This is the photo from August 2022, 3 years ago. And you can see that the retina is almost looking the same, absolutely same. You have the fibroscular polyp here at the disc, you have the macula, and look at the OCT. Even the OCT is absolutely same, it looks like a Xerox copy. So you have September 22, this is the situation where the macula is attached, barely attached but still attached. This is April 24 and this is now recent June 25. You can see the macula still attached. Patient is maintaining vision of 6/24. So this is a situation where I would not advise surgery. So this tractional retinal detachment is remaining stable for nearly 3 years, and it is possible that if you do not intervene, it may remain stable for further more years. So by doing surgery, you are not going to help the patient. What will happen is during your surgery, the macula is going to get detached because your manipulations and sometimes the membranes will be so adherent, so it will cause traction on the macula. Once the macula gets detached, whatever you do, even with successful surgery, the post-surgical visual outcome is going to be lesser than pre-operative. So this will result in a very unhappy patient. So best is to leave the patient at this stage, let the macula be like this, and the patient may enjoy this vision for the next 1 or 2 years. Once the macula gets detached, you are justified in offering surgery for this patient. And I have many such patients, many such examples where I have observed the patient. So this is another case where you see almost 360-degree prolif is there. There is tractional retinal detachment. Macula is showing some schisis, but still it is attached. Patient has fairly working vision in this eye. And this remained like this for 4 years. After 4 years, this patient came with macular detachment, and that is the time when I did the surgery for this patient. So surgery outcome is okay, silicone oil removal has been done, but patient's vision is about 3/60. So that is the vision you expect in such a situation. So which will be less than what preoperatively he had. So rather than this is another case where you see almost a circular proliferation with tractional retinal detachment, but the macular foveal area is attached. Now with this kind of a situation, the patient is maintaining vision in this eye and he is able to do all his daily routine work. So again, this is a situation where I would not intervene. I feel it is more important to know when not to intervene or when not to do surgery than to know when to do surgery. So this is an important aspect I would stress here. As opposed to this, you have other situations where you will see a proliferation. Most of the retina is quite okay, and you see the OCT. It shows traction on the fovea, and these patients are symptomatic, so they will complain about decreased vision. Now, this is the other eye of this patient. If you have frank tractional retinal detachment involving the fovea, you are obviously going to offer surgery. But in this situation where the entire retina is almost attached, but there is traction on the macular area, sometimes you are you fix whether to do surgery for such patients or not. But there are situations where, like this lady, 63-year-old lady, who came with one eye is lost, it is thiacical, and this is the only seeing eye. You can see there is some proliferation here, there is one proliferation here with some focal TRD, quite well lasered. There is these are some cataract spokes, and if you see the OCT, it is showing you foveal traction with a thick fibrovascular prolif over it, and this is a very symptomatic patient complaining of loss of vision. So we offered her surgery, and this is post-surgery. You can see macula is okay. This is immediately, I think, within a week of surgery. That's why you see all these undulations because of the edema. But vision is restored to 6/18. So in this situation, it is beneficial to operate, but these decisions have to be customized. So we come to the management of cataract along with proliferative diabetic retinopathy. Dr. Divya already showed a nice algorithm about how to go about. Just to add to that, if you have, say, a well-controlled proliferative diabetic retinopathy, well-lasered retina, and you have a cataract which is significant, definitely go ahead and do the cataract surgery as you would do in a normal patient, and then keep on following the diabetic retinopathy. But if you have an untreated diabetic retinopathy or an active looking proliferative diabetic retinopathy, then it is always good to do the treatment first, which is here the laser is the, I think, the choice of treatment, because as I said, the anti-VEGF is quite dangerous. As you can see, some proliferation, some fibrosis here and large prolifs, so laser is a much safer option. You can do laser to the extent possible and then go ahead with cataract surgery. But when you have a when you have already a proliferative diabetic retinopathy with vitreous hemorrhage, membranes, whether to do a combined cataract surgery along with vitrectomy is the question. And in this situation, I follow a very simple algorithm. If you have a posterior segment problem which is a little bit mild, that means you do not require too much of manipulation, then you can do a combined cataract and vitrectomy surgery. Such as in this case where you have probably only vitreous hemorrhage or only few membranes where you do not expect much manipulation and do not expect to put silicone oil, etc. You can go ahead and do cataract surgery with combined this thing. As opposed to this, if you have if you have a case where there is a significant posterior segment pathology, significant tractional retinal detachment, large prolifs where you expect a lot of a lot of manipulation required, then I would suggest not to do combined surgery, then to do only a vitrectomy, take care of the polyp and settle the retina, and the cataract surgery can be done in a more controlled manner later on along with silicone oil. So this is one young patient with not much of cataract, but you can see a very extensive proliferation. Almost, this is actually after anti-VEGF, so the proliferation is looking white. But when we saw pre-operatively, it was totally a red, very angry looking polyp, and you can see this proliferation is extending right up to the aura. With very densely adherent. So this kind of cases where you have to do a lot of dissection, there is bound to be a lot of bleeding. So these are the cases which will have a lot of post-operative inflammation, and they will not have any good outcome. So to combine these with cataract surgery is not a good choice, because the cataract surgery also will throw up inflammation, and these are the cases where you will see a lot of anterior segment adhesions, IOL displacements, etc. So these are the cases best done singly. So we come to the role of anti-VEGF in PDR. Again, already Dr. Divya and Manavi has also mentioned. So this is a situation where most commonly it is used as a pre-operative tool. So you have a situation where you have large polyps here, you can see very angry vessels, and if you do surgery with this situation, there is a likelihood of excessive bleeding, which will cause further complications in your surgery. So this is 2 days after anti-VEGF. You can see already so much of fibrosis, but the vascular loops and all have become much better. So this makes your surgery slightly easier. Not completely less out of risk, but the risk is still there, but still it becomes slightly better because the bleeding is controlled. But this has to be done within 3 to 5 days, otherwise you will experience a crunch phenomena here. Another situation where anti-VEGF can be given in PDR is after a complete panretinal photocoagulation is done. So this is one patient, a 30-year-old juvenile diabetic man, uncontrolled diabetes, HbA1c is very high, and he comes with a very large NVD. You can see a very large NVD here. This is the right eye and this is the left eye. This is a treatment naive case. So first treatment is PRP. So we have done panretinal photocoagulation here, but you can see this NVD still persists in both the eyes. This is the right eye, left eye also the NVD still persists. But there is some area for left for laser, so we advise a fill-in panretinal photocoagulation, and that is also done. Patient comes back after fill-in panretinal photocoagulation, and you can see the NVD is still active. There is some pre-retinal hemorrhage here, and this is the other eye. Other eye also you see some NVD is still active. But in this situation, notice that there is no fibrosis here. It is only the vascular loops or the NVD. So I advised anti-VEGF treatment for this patient. And so this is after the second dose of anti-VEGF injection. There is some reduction in the NVD, although not much. You can still see some large loops of vessels. The left eye shows a slightly better response in the regression of the NVD. So further anti-VEGF was given, and this is after the third anti-VEGF. There is a little bit better regression. You can see the almost gone, the NVD is gone. You can see the retina is absolutely well lasered. There is no space for further laser or cryo, etc. So that's why I gave this anti-VEGF to this patient. And this is the latest photo in the last month. You can see again there is some new vessels here. So anti-VEGF is not the full and final treatment. Even after giving multiple doses of anti-VEGF, the patient is still having recurrence of NVD. So again I have advised anti-VEGF for him, so he will come. But this is a situation where there is nothing else that we can do. This is not at a stage where vitrectomy is indicated, and already there is no space for any further laser. So anti-VEGF I feel is the only choice for this patient. And the anti-VEGF is being given, say, in about once in 10 months like that, he is needing anti-VEGF. So once a year he is getting anti-VEGF, which I feel is actually all right, not a too bad a situation. So this is a situation where careful anti-VEGF can be given in PDR cases. Another situation which Dr. Mahesh mentioned is for recurrent vitreous hemorrhage following vitrectomy. Most of the patients, 85% of the patients, it is because of some fibrovascular proliferation development at the sclerotomy site. So this definitely helps with anti-VEGF, and because already vitrectomy has been done, so the chances of crunch and retinal detachment occurring is very less. So this is a safe option, and many times the vitreous hemorrhage can get controlled with anti-VEGF alone. But I would not advise giving anti-VEGF to a patient of vitreous hemorrhage where no surgery has been done, and there is also no view of the retina, which is a little bit dangerous proposition. The next we come to this combined retinal detachment. Combined retinal detachment, you can often see diabetic patients who are neglected and ignored. They come with combined retinal detachment where there is tractional element as well as rhegmatogenous element. And this is by far the most difficult situation for a vitreoretinal surgeon to handle, because the surgery is very, very difficult. The retina is very thin and mobile. There is no counter traction in these situations for membrane dissection, and identification of the posterior hyaloid, etc., becomes extremely difficult. So this requires a good preparation from the part of the surgeon. You make sure that there is a thorough evaluation of the ocular status as well as the systemic status, followed by make sure that you have good quality instruments, good visualization system, and good support system. Anti-VEGF is of definitely good choice. It can help you, it will help you with the surgery and make the surgery a little bit more favorable and less risky. Of course, the crunch phenomena needs to be taken into account. The most important key considerations for surgery in this situation is that you have to remove the vitreous completely, including the posterior hyaloid. And this posterior hyaloid is not like a normal hyaloid which is attached only at one place. It has got multiple attachments to the disc, to the vessels, to the proliferations, the retina. And you have to make sure that this there can be also vitreoschissis, and you may have multiple membranes. So you have to make sure that you are identifying these membranes correctly, and you are removing the entire vitreous. So here you see this side there is no PVD, and this vitreous is adherent to the retina. So it needs to be identified and removed. Sometimes you can take the help of scissors to cut these polyps. So you can see here, if you leave any vitreous which is residual vitreous, whether it is like a band or a sheet, if it is bridging between anterior and posterior areas, it is sure to cause traction and lead to recurrent detachment. So make sure that there is no vitreous bridging across 2 points like this. The second key consideration is to find the correct plane of dissection for the fibrovascular proliferation. And this is a very highly magnified view of the OCT. You can see that this is a fibrovascular prolif, and this is the membrane part which goes along with the posterior hyaloid. And the common mistake is to start dissection here at this level, thinking that this is the plane of cleavage. But this is actually the wrong plane of cleavage, and you can see there is a membrane which is growing on the elevated retina. It is growing back on the elevated retina, and this is called as a second membrane, a surface creeping second membrane. And the real plane of dissection is actually not there, but under this membrane. So this is the membrane which you need to lift and get into the correct plane of dissection. So if you see here, this second membrane extends quite farther apart from the original prolif. You can see from the prolif there is these kind of spokes you can see which are going. It's like a sheet of membrane sometimes, and here I am trying to lift up this sheet of membrane. It can be it can come out easily, or it may be slightly adherent, and you may have to cut those adhesions. But once you lift up this membrane, then you have entered the plane of cleavage, and then it is easier to do the dissection of the membrane. In the correct plane of cleavage, when you are dissecting, the chances of iatrogenic injuries, iatrogenic retinal break or bleeding is much less. As you can see that you can see this proliferation, although it's a very thick prolif, very large and quite adherent, but it comes off quite well. So what I'm lifting up is actually the second membrane only, and you may have to search at 2-3 places to exactly locate this membrane, but once you locate it, it will help you. And so this is now the correct plane of cleavage. I hope you have understood the plane of cleavage. Now in this plane of cleavage, you can see the surgery can go very atraumatic. You need not have any bleeding, you need not have any break, and sometimes the membrane can roll very easily. So I almost always insist to all the fellows that they must try and identify this plane for proper dissection. So for want of time, maybe I will just go forward. So second key is sometimes you may have to do a bimanual surgery. So sometimes in combined retinal detachment or in very extensive prolifs, it will be very difficult to do unimanual surgery. So bimanual surgery with the help of a chandelier, when you have forceps in one hand and the scissors in one hand, can give you a much more stability, and it will be easy for you to lift the membrane and cut the adhesion points. So this may give a slightly better outcome than you are struggling with just one hand. So this is one patient with combined RD, and you can see the dissection is being done fairly atraumatic, with not much of bleeding, not much of retinal traction, no holes, no breaks are created. And sometimes you can use a cutter for dissection of these membranes, whether they are flat or elevated, or if there is retina is attached or retina is detached, you can use the cutter. Now with advancements in technique, you have a very stable fluidics and you don't have much traction on the retina. Previously, this kind of manipulation would have been very dangerous, because the retina can jump into the cutter and can cause you can have an iatrogenic retinal break. But nowadays, with with the advanced machines and technology, we are able to do that. So here the cutter is being used to cut the prolif. Although this is not my favorite technique, I use the scissors, but nevertheless you may have to use both cutter as well as scissors to cut the membrane. And so this is, and then you of course you have different techniques to feed the membrane. This is the newest innovation which I was talking about, is the Hyperwit, which is the newest cutter from Alcon. And the features of this is that it has a flat kind of a sloping edge here, which goes more close to the retina. So you can go under the membrane, in between the membrane and the retina, and can cut the membrane quite safely without damaging the retina. And moreover, it has got dual cutting. So the cutting blade, it has got both dual cutting. So it has improved efficiency for vitreous clearance. It has got stable fluidics. So you can see it has got 20,000 cuts per minute, which is, the retina remains very stable, does not even fluctuate. And because of the bevel tip, you can go closer to the retina. So this way it makes the cutting of the fibrovascular membrane very safe. So this is another technique where you have proliferation without any vitreous detachment at all. So in this situation, you can go from center to periphery, and this is where I am giving a cut over the disc area with scissors. And once you start cutting the membrane from the center, then you can go to the periphery and start dissecting the membrane. So this is very useful technique, especially in situation where there is a completely plastered proliferation with no lifting of the vitreous at all. So this is the center to periphery technique of the dissection. So the various complications of proliferative diabetic retinopathy and vitrectomy are there, which I need not go into detail, but you can have reproliferations, you can have recurrent RDs, you can have recurrent vitreous hemorrhage, you can have NVG. So this by no means this is an exhaustive discussion of the proliferative diabetic retinopathy. I am sure there are many more points to discuss. However, for the want of time, I would like to conclude here by saying that the proliferative diabetic retinopathy is a challenging situation to manage, and there is no one size fits all technique here. You have to customize for each and every patient, taking into account a lot of points which I mentioned in the beginning. You must customize the treatment for individual, but you must make sure that the basic principles of the surgery are followed to have successful outcomes. Thank you very much for your kind attention.